Good morning, everyone, and welcome to Cardiac Sciences Grand Rounds for May 28th. This morning, we have one of the bright lights here in Calgary, Cardiac Sciences. Our rehabilitation group is speaking to us. I'm really looking forward to this. Our rehabilitation group has long led the country in both clinical service to the community. Anyone who looks after post-MI patients realizes the importance of this group to the Calgary community, and also in research and data analysis. So this morning, we're going to hear from them, and they're going to speak about enhancing outcomes from cardiac rehabilitation, a team science approach. Dr. Sandeep Aggarwal, who is one of my predecessors and is head of the rehabilitation group, is speaking. Dr. Steve Wilton, who is the executive director of the SCN and also involved with the rehabilitation team, is speaking. And Codie Rouleau, a PhD who's involved in data analysis and is a physiotherapist, is that right originally? Or a clinical psychologist, sorry. I will be speaking as well. So welcome, and we look forward to your talk. And we'll start off with Sandeep.
Okay. Find it. Okay, here we go. Share.
You want to share screen?
Okay. Hopefully everybody can see that okay. Awesome. Well, thanks, Andrew, and thank you, everybody. I think it's been a long time coming for us to come and present to you guys. So really going to focus more on the research side of things, but I'm going to present a bit of our clinical information. So just our disclosures, we do receive some research funding, and Dr. Wilton also specifically put his research funding in there as well. And then just our land acknowledgement, Treaty 7 territorial land acknowledgement in the spirit of reconciliation. TotalCardiology Research Network acknowledges that we live in, work, and play on the traditional territories of the Blackfoot Confederacy, Tsuut'ina, Nakota Nation, and Métis Nation Region 3, and all people who make their homes in the Treaty 7 region of Southern Alberta. So the outline of today's talk is I'm going to talk a bit about an overview of cardiac rehabilitation and the modern challenges. And then Dr. Wilton will talk about a team science approach to improving cardiac rehab outcomes. And Dr. Rouleau will talk about our current research initiatives and future directions. Slides. So just to start, just as a background, just to remind everybody that cardiac rehabilitation is globally recognized as a standard of care for the prevention of cardiovascular disease. Both the European Cardiovascular Society, Canadian Cardiovascular Society, American Heart Association, all recognize this. And there's evidence that suggests that there is a decrease in myocardial infarctions, all-cause mortality, as well as all-cause hospitalization, and an improvement in cardiorespiratory fitness, risk factors, and psychosocial functioning. But we know, what we really know is that we are not doing as good as we think we're doing, and that's always the case. And here's some Canadian data from Quebec hospitals of STEMI patients. And what they showed was post-PCI, you'll see here that despite being on pretty good discharge medications, these patients still have a pretty high mortality rate over 10-year period of time, and a very high recurrent ischemic heart attack event rate over that 10-year period of time. So 42%, despite the use of secondary prevention medications. What's not really clear here is that what were they on at 2 years, 3 years, and 4 years, which is sort of emphasizes the benefits of cardiac rehabilitation, which is the importance of compliance beyond that discharge medication. So you've done a great job at discharge. What happens to them after that? Do they stay on their meds? Are they exercising, et cetera? So again, we continue to have recurrent events. How do we help prevent those recurrent events from occurring? Just as a background for cardiac rehabilitation in Calgary, it really was started by cardiology consultants back in 1996 under Don Meldrum and Jim Stone, both who have retired. And back then we saw about 400 patients a year, and we had a 3 to 6 month wait. And now we see over 1,800 patients a year and a 2 to 4 week wait. So big difference, and we'll talk a bit about that. Our types of patients have changed as well. Initially, we saw patients who just had acute coronary syndrome, chronic coronary disease, and post-bypass. But at the request of our departmental members, we've actually expanded it. So heart failure reduced EF, transplant patients, VAD patients, post-AVR, mitral valve replacement, thoracic aortic surgery, CABG prehab, so before they have their cardiac surgery, POTS patients, peripheral arterial disease patients, atrial fib patients with risk factors, and we're doing that as a research study. Early surgical access, which we recently started in the last year to catch those patients right soon after they've had their cardiac surgery to try to capture any sort of negative things that happen, infections, et cetera. And actually have some good data on that as well. We won't be showing that today. And then with the help of Dr. Howlett, we've added a heart failure continuity clinic to again capture those patients early after they've been hospitalized with heart failure. And again, early is really a key word in some of the work that we do. Here's some of the early work that we did looking at early access and how this influences particularly patients coming to cardiac rehab. And what we did was we said, and people remember the STEMI project. I was part of that STEMI project, getting patients from home to the cath lab, door to blue time, reducing that door to blue time. Remember all those meetings, getting the ECGs and in the ambulances, et cetera. There was lots of work that was done, and we were leaders in the country for that. This is the next step. How do we then get them back home efficiently? And so Dr. Goodhart came and asked me, hey, you guys really should be seeing these patients early instead of us. And we said, sure, let's do it. Let's give it a try. Nobody else had been doing it in the country. I was told by some of my colleagues who are research leaders in rehab, say, don't do it. We said, we're doing it. So we did it. We saw these patients early, 2 weeks after discharge, within 2 weeks after discharge from the hospital. And this is the results of what we found, was that we improved completion rate. If you look far on the right-hand side here, we improved completion rate from 30% to 72%. So we more than doubled the patients who actually came to cardiac rehab. And I was asked when we presented this at an approach meeting several years ago, well, why is that? Well, if patients get a call within 2 weeks after they're discharged from the hospital, they think of that as being like a normal progress of their care. Whereas if they get called 3 months later, they're like, who is this? And it really makes a difference. The psyche and the psychological component of it is super important, I think, to patients believing that this is part of their care. And so we actually presented this at the Canadian Cardiovascular Society, and nobody actually believed it actually was sustainable. And we are still doing it. We're still seeing patients early, and we're still maintaining that early access and patients coming to cardiac rehab. And we're close to that 70%. I think we're 70 to 75% completing cardiac rehab. Well, cardiac rehab is a team approach, right? We need multiple different people to help us be successful. So we have administrative support staff, we have clinical psychologists, kinesiologists, certified exercise stress test assistants, registered dietitians, and clinical psychologists. And then we have multiple clinicians, registered nurses, nurse practitioner, and then we have physicians, but not just cardiologists, internists, and family physicians. So again, the group is very diverse to allow us to actually take care of these patients efficiently. And one of our internists actually decided he wanted to be a lead on seeing the patients early post-surgical, and he's done that work. It's been amazing. Dr. LeBlanc from the Peter Lougheed Hospital, and done quite a bit of that work along with May, who is our nurse practitioner, looking at these patients early. And she worked in the surgical part as a nurse practitioner at the hospital. So she was very well aware of these patients. So what are the components of our cardiac rehab program? We've learned a lot since the pandemic that we can actually change how we provide the care. And we learned that a lot of times patients actually do better when they exercise on their own at home. So we actually did a quicker transition. So these patients are seen by us from week 1 to week 6, on-site supervised exercise. They have core education classes that are delivered virtually. And we actually shared this virtual education with other rehab programs because during the pandemic when they really needed the help. And then from week 7 to week 12, we try to transition them to a home-based exercise to make it more likely for them to be sustainable in exercise, and then weekly virtual group exercise as well. And so what is it that we're providing? It's secondary prevention. You guys all know this. LDL less than 1.8, blood pressure less than 120 on 80 for the SPRINT trial, A1C less than 6.5 most of the time, but sometimes less than 7%, smoking cessation, diet, and exercise therapy. So that's the base of what we do. But we must not forget that there's a lot of new things, and we are slowly trying to incorporate the new things into how we take care of patients from the secondary prevention standpoint, and that is more aggressive reduction in LDL, residual inflammatory risk, trying to see if we can improve inflammation. We know that's important for cardiovascular disease, residual thrombotic risk. So looking at things like the COMPASS trial, aspirin rivaroxaban, residual triglyceride risk with icosapent ethyl, residual lipoprotein A risk. We know that that's a risk factor. And soon we're going to have trials that are going to show whether or not it makes a benefit to treat lipoprotein A. That's going to be coming out actually next year. And so we'll have some more evidence on that. And then residual diabetes risk, which we've seen over the years how we've improved our use of SGLT2 inhibitors and GLP-1 receptor agonists for these patients. So there's a lot to do from the secondary prevention standpoint, and you need a program that's going to actually actively look at these things and see how can we incorporate them, because not every patient's going to want to take everything. So you got to figure out where are you going to find the benefit? Well, we have lots of challenges in cardiac rehabilitation. And so what are those big challenges? So we have widespread underutilization. So we're still only 70% completion rate. We could be better than that. Behavioral change is complex. I didn't realize how complex it was until we had a clinical psychologist working with us and actually working on how do we change behavior. And we don't really get taught this very well in our cardiology programs, but it's super important because it's one thing to give a drug. How do you make sure they stay on that drug? How do you make sure that they continue to exercise? How do you make sure that they come to rehab? All these things are behavioral changes. What is the mechanism of action has not been really clear. How does cardiac rehab help these patients? And we've been working on some of that. Codie will talk a bit about that. There's lots of individual variability. Some patients do really well, some don't. How do we pick the patients that aren't doing well and improve them more? And our patients, and you see this at the hospital, are getting much more complex. So we're seeing these very complex patients. And then there's many other obstacles to, EMR integration. Remember, I'm the big EMR guy, but I know there's lots of issues. And despite my best attempts, there's still lots of challenges to making sure that you can actually get the patients to rehab and send their referral. And so because of that, we have developed a research network to try to help us address these barriers and to try to improve cardiac rehabilitation. And I'm going to let Steve take it from here.
Thanks, Sandeep. Hope everyone can hear me okay. As you all know, I'm a cardiac electrophysiologist, and so you might be wondering if I'm just lost or if I got lost trying to find something, some electrograms, and I wandered into a Total Cardiology Research meeting, but actually I have really drunk the Kool-Aid, and I think this group is doing amazing things, and it actually has important role to play in all sorts of cardiovascular patients, including our own arrhythmia patients. As Sandeep mentioned, right from the start of Total Cardiology, or what was Cardiac Wellness Institute, they collected data. Dr. Stone, Dr. Meldrum had a database that was initiated right at the start, and that was really amazing foresight and allowed some of the work that you saw already. So doing academic work as far back as the early 2000s. And I think what happened was the success became known, and more people started wanting to work with their data, and they developed some collaborations, some that have really been long and very, very fruitful. So Dr. Ross Arena from Chicago is a leader globally in cardiovascular rehabilitation research and has been a huge support and partner in a lot of the work that we've done. As well, Dr. Tavis Campbell from here in Calgary, a research psychologist and clinical psychologist who has led a lot of the behavior change work that we're going to be talking about. And then people like me who just love large databases sort of got involved. And I think one thing that became clear as all of these sort of people came together is some things needed to be formalized, lots of data requests, lots of protocols coming in and needing to have a way to sort of manage it all within what is really at its core still a clinical service delivery model without a big academic footprint. So I think it was really I think it was Sandeep's idea to develop this more formal network. And I was happy to be able to join and sort of guide from an academic point of view. And so we set up this network with policies and procedures, and really with the mandate to explore some innovative research questions that relate to secondary prevention, primary prevention, and all forms of cardiovascular disease, to provide more of a structured process for looking at proposals that were coming in and getting people to use the data, set a forward-looking agenda, disseminate our findings, and provide some exceptional training opportunities. And actually, that's where I'm going to start. Oops, wrong way. is with the training. So since 2009, the TCRN has held an annual day-long retreat for trainees who are interested in working with the data. And it's a very structured program. I'm not sure if any of those who are here today have participated in it, but some of the cardiology trainees have. And a number of trainees from other disciplines and even other universities have come to play with us for the day. We identify 3 or 4 trainees quite early, several months ahead of time, who are working with one of the mentors in the program. And they have to actually do 3 presentations on the day of the meeting. Usually is in the spring. It was in April this year. They have to prepare an abstract, and we give them access to Total Cardiology / approach data to do that if they want. They have to come with a proposal for a new project that they plan to work on over the next little while. And then we get them to talk about their career planning. And that's really, really been a fruitful conversation where people talk about what they're interested in, and we give them potentially some advice, and we learn from them a lot of the time. So these are really, really fun meetings. And we just had the 5th one last month. It was really well attended and a successful event. The other reason I'm here is that as many of you will know, I work with the Approach group, and it really is a natural partnership to work between the Approach Cardiac Catheterization and Outcomes Registry and the Rehab group. So obviously we have lots of overlapping patients in the 2 data sets, with the main limitation being that TCR is limited to Calgary, whereas Approach is provincial, but it's still a huge number of patients that overlap. We obviously have convergent interests in terms of studying and improving the outcomes of people with heart disease. And we have data that complements itself. So Approach has always had all of the coronary anatomy data, all of the data about the initial presentation, some of the stuff about the hospital care, and then the long-term outcomes in terms of mortality and hospitalizations. But we haven't had all of that intermediate stuff in between, which is where the rehab program comes in. And their database is exceptional. It really has a ton of different rich data about patients, not just at one time point, but at many time points that are fun to work with. Oh, and we have done that. So putting together Approach and rehab data has led to a total of 17 papers published over the last decade or so, allowed 17 trainees to publish first author papers and achieve peer-reviewed grant funding, including a CIHR funded trial that Codie's going to mention a little bit later, and has, in terms of working with the data, has culminated in this very comprehensive heart care data set, which again, Codie will talk about a little bit later. I'm just going to spend a few minutes highlighting some of the previous work that's been published. Some of you might remember Billie Jean Martin, who was a cardiac surgery trainee here and trained with me in research at the same time. And she was one of the first trainees to actually work with Approach data. And she published this quite seminal paper about mortality benefit with cardiac rehabilitation related to completion of cardiac rehab. So this is one of the main pieces of data that underlies some of the stuff that Sandeep was talking about at the start. Large data set, really high quality data, and a prominent publication. A couple of years later, using a very similar data set, Dr. Colbert studied and actually was one of the first, I think, Libin-associated investigators to study sex and gender differences in cardiac processes, and in particular cardiac rehabilitation. And what she found was perhaps not surprising, but still needed to be shown, was that females compared with males were less likely to be referred to cardiac rehabilitation after acute coronary syndrome or for other indications by a substantial margin. And if they were referred, they were less likely to complete the rehabilitation program, again, by about 10% absolute. Highly statistically significant, reasons not very well explored within that data set. And then the other important thing is that though if they did attend and if they did complete, their benefits were just as good as for the males. So it really identified an area that we needed to work on. This is a project about process of care and how it can improve things. So Sandeep mentioned the early access being really, really important at increasing enrollment and completion of the program. Another thing that was done in the cardiac surgical program about 15 years ago actually was just automating the referral. As opposed to it being a box that you have to check if you want the patient to go to cardiac rehab after the cardiac surgery, you have to initiate a referral. It's just automatically done at time of discharge. And what this study showed was that doing so actually just we used this sort of interrupted time series analysis method to do this, showed a really sort of stepwise jump in the referral rates up to about 85%. And that led to a much more modest improvement in the actual enrollment and completion rate. So we know that automating the referral has some effect, but it's not everything. We still need to engage with the patients and motivate them to keep going. George Liu, who was the first author on that last paper, also did his PhD using a linked approach and TCR data set, focusing on atrial fibrillation. So I wondered, and we wondered, whether one of the benefits of doing cardiac rehabilitation might be to prevent the occurrence of atrial fibrillation, because we know there's shared risk factors between coronary disease and atrial fibrillation. And there's been some growing evidence about the benefits of risk factor modification in patients with who have established atrial fibrillation. What we were looking at in this study is, did it prevent the incidence of atrial fibrillation? And we took patients who had had a PCI or a CABG and were referred to cardiac rehabilitation and looked at the effect of program completion. And before you adjusted for any variables, there seemed to be an effect of program completion on incidence of atrial fibrillation, but that didn't survive after adjustment. However, we did see that both the baseline cardiorespiratory fitness, so the amount of exercise a person could do at the start of the program, and how much change or how much benefit in terms of their exercise capacity that they had during the program, both reduced the risk of atrial fibrillation developing in the future. So just another little bit of evidence, if you weren't already believe that exercise is medicine. George did some interesting sort of sub-analyses on this, looking at, is there a threshold effect? And we did find sort of a linear decrease in the incidence of atrial fibrillation based on either both baseline and change in METs with the program that sort of plateaued off after 9 or 10 METs. So once you're reasonably fit, you don't get a lot of additional benefit, but going from quite sedentary to just moderately fit can actually be quite helpful. This is another study looking at another subgroup of patients who, in some ways similar to the female subcohort, or tend to be overlooked and neglected. And this is patients with chronic kidney disease. And in this study, they found that patients with chronic kidney disease who, had an indication for cardiac rehab, whether it was an ACS or CABG, were less likely to start. These weren't dialysis patients, by the way. These were anyone with sort of moderate or more chronic kidney disease, less likely to start and less likely to complete cardiac rehabilitation. But again, similar to the other story, if they did do those things, a substantial improvement in the risk of death in follow-up. Last sort of database-driven study that I'm going to tell you about. This is a more recent one where, along with Dr. Arena from Chicago and some colleagues in Stanford and Brazil, we allowed them, these machine learning experts, to play with this linked data set and to try to use different methods to determine the benefits of cardiac rehabilitation and what the predictors were. And we thought at the start of the project there was going to be some really fancy algorithm come out of it. But what showed up actually is just being fit is the most important predictor of survival, as well as being younger, right? So all the other risk factors that we looked at actually played a minimal role in terms of improving the prediction of the model. Smoking was a moderately important predictor. But if what you're looking at is long-term mortality, being younger, being fitter is better. Not really, I think, super shocking information, but this paper has been super well cited, I think because it's machine learning based or something. So I think now I'm going to pass it over to Codie to talk to you about some of the ongoing work.
Okay, so I'm going to continue the blitz of recent and ongoing research that our team is involved with, switching gears to some of the projects. The most notable one is the Heart Care study, which is a retrospective cohort study of rehab referrals linked with other data sources, including Approach from 1996 to 2019. And this data set has enabled us to look at several important questions that can address the challenges Sandeep talked about earlier, namely to start to understand in a more nuanced way how cardiac rehab works. We have this multi-component intervention that clearly demonstrates survival benefits, but unlike pharmacologic interventions where it's standard practice to look at mechanisms of action, this isn't routinely done in behavioral interventions. So the question of how and why do people live longer? Is it the fact that they get more fit, or is it because they're less depressed, or is it because we're improving their lipids, or what's going on? So that's one of the important things we've been able to look at. We've been able to examine variability in treatment response and better understand the influence of cardiac rehab in different patient subgroups. Our latest publication from this data set, it was actually just published last week or the week before in Journal of the American Heart Association, looked at a subgroup of patients who had been referred to cardiac rehab post-ACS, 2009 and 2019. And these were all first referrals to cardiac rehab. And what we were looking at was this question of what are the main active ingredients in this multi-component 12-week intervention that we offer to patients. And so the sample was fairly typical cardiac rehab research, about 3/4 male, average age around 60, and mainly out of target risk factors at baseline with a few exceptions, namely blood pressure was well controlled on average. And not surprisingly, we replicated decades of previous research showing an association between completion of cardiac rehab here in Calgary and survival. And this was true for attendance as well. So each additional exercise session that patients attended corresponded to about a 2 to 3% reduction in all-cause and cardiovascular mortality. Not surprisingly as well, we observed improvements from pre to post cardiac rehab in risk factor profile. So clinically meaningful improvements in cardiorespiratory fitness, in lipid control, in psychological distress, and so on. But here's the novel finding here. We conducted mediation analyses, which are designed to examine mechanisms of action, like the ways through which cardiac rehab attendance might influence mortality. And as you can see, we observed that cardiorespiratory fitness, surprise, surprise, is really important. This is probably one of the main active ingredients for many of our patients. There was an indirect effect of cardiac rehab attendance on cardiovascular mortality via improvements in cardiorespiratory fitness. There was also an indirect effect of cardiac rehab attendance on all-cause mortality via fitness improvements and via LDL levels. So this suggests these are two really important components of secondary prevention, and should continue to warrant careful attention in the months and years after a hospitalization for ACS. Another recent study that came out of the HeartCare data set, this is being headed by my master's student in clinical psychology, Laura Hernandez, and she's looking at the underappreciated outcome of mood and anxiety. We know that these represent two psychological risk factors, that elevated levels of anxiety and depression are linked with the development of cardiovascular disease and worse outcomes from cardiovascular disease. And it's been widely reported that people who complete cardiac rehab feel better from a mental health perspective. But the extent to which these improvements in people's mood and anxiety are clinically meaningful hasn't been well evaluated. So what Laura was able to demonstrate was that quite remarkably, among patients who start cardiac rehab and score in the elevated range on our depression and anxiety screening instrument, about 1/3 experience clinically meaningful improvements on the hospital anxiety depression scale, which this is kind of a good news, bad news story. Like on the one hand, it's quite remarkable that completion of a supervised exercise training program contributes to meaningful improvements in mental health outcomes, given that there isn't like a specific mental health component to this intervention. At least in this sample, we excluded anyone who had was undergoing concurrent psychotherapy. The bad news is there's still a significant subset of patients who don't feel better after cardiac rehab. So these data help us inform stepped care models to capture patients who present with persistent symptoms of depression and anxiety. And the other preliminary finding that came out of this data was that patients who reported improvements in their symptoms of anxiety from pre to post cardiac rehab were less likely to die at follow-up. So there was this association between improvement in anxious symptoms and reduced risk of all-cause mortality in the subset of patients who were anxious to begin with. So she will be defending these findings in her thesis defense in a few weeks here. Another noteworthy recent trainee project headed by Danilo Iannetta, postdoc at in Department of Kinesiology at U of C, looked at our data during the height of COVID public health restrictions. So this was August 2020 to October 2021. If you recall, everything was shut down, no gyms were open. Our clinic was largely operating virtually with the exception of a pre and post visit with the physicians. But all of the exercise training was being done by patients at home with follow-up support by telephone. And what Danilo was able to demonstrate was that our program still influenced people's cardiorespiratory fitness even during this crisis period when patients weren't receiving on-site supervised support. So really encouraging news that we can be nimble as a program and help people improve their exercise capacity. And we've retained a lot of these changes in the program even after the public health restrictions were lifted to help people exercise at home and in their own community. And then, another noteworthy study really to address the issue of increasingly complex patients and the potential utility of cardiac rehab in patients that we normally don't see. This was a pilot study that we performed a few years ago looking at prehab before CABG surgery. So we offered supervised exercise training to patients awaiting bypass surgery, which is a really crucial time. This is a time when patients are highly anxious. They're nervous to move at all, let alone do, low intensity physical activity. And it's also a time when generally people's cardiorespiratory fitness can decline. And what we found was that kind of initiating this exercise training and risk factor modification through cardiac rehab earlier in the cardiac care trajectory improved people's fitness while they were waiting for surgery, improved their body mass index, and improved their level of psychological distress. And also noteworthy is that patients who completed prehab while they waited for CABG were more likely to join us for rehab after surgery by quite a significant margin. So there was a 14-fold increase in enrollment among patients who completed prehab before surgery. And this program now continues. We continue to offer prehab before CABG. And then finally, I said I was going to talk about recent studies. This one's kind of old now, but interesting, highlighting some of our ongoing work on behavior change and incorporating the behavioral sciences into cardiac rehab to improve patient outcomes. As Sandeep mentioned, one of the core problems in cardiac rehab is that it only works if people attend and participate, just like medications, like they only work if people take them. But the difficulty with cardiac rehab is this is a complex behavioral change regimen. We're asking patients to exercise, take their medications, change their diet, uh, you know, engage in like glucose monitoring, do all this stuff, which is a hard thing to do in the long run. So what this study did was it was a randomized controlled trial testing a brief motivational intervention, like a brief counseling intervention that incorporated theories of health behavior change and principles of motivational interviewing delivered after patients were referred to cardiac rehab, but before they enrolled in the program, and compared this intervention to usual care, which, by the way, usual care in Calgary is quite a high bar. Like we have quite a widespread recommendation for patients to attend cardiac rehab by their referring providers. We also have a high bar for like a lot of people already come to our program, but despite the high standard we were comparing this intervention to, there was still a significant effect of this brief conversation with patients after referral on increasing patients' intention to join cardiac rehab. It improved their views about cardiac rehab, like patients were more likely to perceive that cardiac rehab was necessary for them. And then interestingly, this brief 30-minute consultation with patients corresponded to improved attendance. So talking to patients before they were referred and helping address barriers to attendance led to patients attending on average 5 more exercise sessions, which, as you might recall, there's a clear relationship between more exercise sessions and less chance of dying. So this is an interesting finding in that, number one, this probably isn't generalizable as was tested in this study, like talking to patients for 30 minutes after referral, but the principles of it are generalizable, that we can talk to patients using established behavior change techniques to help support their adherence to this highly effective intervention. So some themes that come out of our ongoing work and some things that we have on the plate in the months ahead are the question of, can we tailor cardiac rehab to different cardiac populations? So right now, we're working with researchers out of University of Ottawa Heart Institute to see if our program remains effective for patients with cardiac devices. We've recently started a pilot project testing the use of cardiac rehab for patients with cardiac amyloidosis. As Sandeep mentioned, we've incorporated a heart failure continuity clinic within cardiac rehab and are actively looking at that data, looking at cardiac rehab for POTS, for patients with AFib and risk factors. We also continue to prioritize research on the components of cardiac rehab. How can we optimize this multi-component intervention to increase the chance that people will get better and to address that variability in treatment response? So some of the things we're currently looking at are the joint influence of exercise training plus medications and characterizing the influence of that combination, looking at levels of LPA in our patients and the influence of that on outcomes. And then more recently, we've incorporated measurement of sleep duration in our standard panel of risk factors. There's a growing recognition that sleep health is probably important to cardiovascular health outcomes. So this will enable research studies in the years ahead, looking at what happens to a person's sleep during rehab and does it matter to influence their longer term outcomes. And then finally, we continue to focus on incorporating behavior change interventions into cardiac rehab. We're currently testing the use of motivational letters to help people stick with their risk factor control in the months after they complete rehab. And then also the CIHR funded study that Steve mentioned, looking at behavioral weight loss intervention as an adjunct to cardiac rehab for patients with AFib. So On that note, we are actively recruiting for this study. It's called the Be Well in CRAF study, the Be Well study. And Steve is one of the PIs on that, along with Tavis Campbell. And the goal of this trial is to test whether the delivery of targeted weight loss intervention plus standard cardiac rehab leads to added benefit for patients with AFib and obesity. So if you have any patients who have AFib and elevated BMI, please don't hesitate to contact the research team to see if your patients might be eligible. It's free. It's a free, high quality intervention that might make a difference to patients. And we, Tamara Williamson, who's my current PhD student, did some early phase research on this intervention, seeing like, would they even want to come to something like this, and use those patient reports and patient preferences to design this intervention in a way that's ensures it's acceptable to people and that people would want to come and would want to stay. So so with that, I'm grateful that we were able to come and share some of these recent research highlights with all of you. I will, the slide went kind of funny, but there's a long list of names here that are being cut off. Big thank you to our TCRN research committee who all participate in this research off the side of their desk. Like, we're not an academic institution, and it takes a lot of passion to keep this research program going. So I think the people not listed here, Catherine Kingshire, who's an academic nurse at U of C, Leslie Osford, Umair Iftikhar. Who else is being cut off? Trina Hauer, who's our former program manager at Rehab and now program director for Total Cardiology. And then all of our trainees, collaborators approach. And then we get a lot of support from Libin-based data analysis services, Moselle Core Analysis Labs, Force Support Unit, and then such strong support from Total Cardiology managers and clinicians and patients that have helped this all unfold over time. So with that, thank you. And all three of us will welcome your questions if there are any.
Thank you very much. That was wonderful. We'll open it up to questions now. Are there any questions in the room or online? I'll open the chat box if people want to put questions in chat, or they can just speak up on the mic. Overhead mics are on. Catherine.
That was fantastic, and it opens up some more questions. I was just wondering, I mean, as I look at some of our patients, trying to get them to be physically active afterwards could be a major challenge. So how physically fit do you have to get them to see any benefit? I know you talked about 9 METs, but I have a feeling that a lot of our patients will not get to 9 METs. So
Actually, 9 was where it started to flatten off. Yeah, sorry. So in that AFib study, 9 was where it started to flatten off, no additional benefit. We started to see benefit at very slight changes, and that's very consistent across literature from other places. So even really small amounts of exercise, if continued in the long term, can be very helpful in terms of heart outcomes.
Yeah, and some of the people who benefited the most are those that are like the most unfit, who actually get a little bit fit, whereas the people who are really fit, they really can't improve in a lot, right? They come in at like 9, 10 METs. And
Yeah, their benefits from rehab are probably going to be in the other risk factors.
Yeah.
and what about the type of exercise? Does it matter?
Not as much as we used to think. Yeah, anything really. Do you have more to say on that?
no, just to say that we do have both components of an aerobic and a non-aerobic component. We get both pieces of the benefit. And we know, like, for example, in the heart failure population, it's important to have both the aerobic and the non-aerobic components in.
Exercise correlate with weight loss, and would you get similar benefit or more if you put them on Ozempic, for or something like that.
Yeah, so what we know from weight loss, for example, is that rehab is not a very good place to lose weight most of the time, which is why specific interventions to help lose weight are what you need to have, like something that's more designed for weight loss, right? Obviously, we know drugs like semaglutide and other GLP-1 receptor agonists do help with weight loss. Whether that also translates in a rehab program is hard to know, but we have lots of good data now, right? We've got tons of data that says that reducing weight using those agents decreases cardiac events. Now, how do you then decide which of those patients you then incorporate it, knowing cost is an issue, into a rehab program? And that still hasn't been fully elucidated. But we're looking to see whether or not that's an option as well.
They've looked at downstream. First you get the patients up in hospital and you looked at downstream afterwards. What about moving upstream for preventative? Is that a way you should go with this whole program? Takes a lot more money and people like, should we be looking at that? Can you take that and make it even more beneficial?
So,
Everyone.
Everyone.
no, so I mean, I think there's already, you're talking about the general population, right? People without established disease, and there's already tons of, provincial based programs that try to promote that with greater or lesser success. And so I think looking at a cardiac rehab model is probably not the solution for a general population of people living all across the province. That's my opinion only. Yeah.
I think you have to decide where you're gonna put your money, right? So if you're gonna do that, you have to decide which patients you're gonna pick. If you pick everybody, that's gonna just be super costly. So for me, I would say that if you can identify like very high risk primary prevention populations, those who have like lots of coronary artery calcium, who have yet not had an event, you might be able to pick people who have a lot of risk factors. You're going to be able to help those patients rather than try to do that within rehab. As Steve said, I think there's lots of other programs where that should be done, but that takes a different degree of effort. I don't think, we're designed
No, I was
necessarily to
just
do
wondering
that.
about your data and using that data to.
There's a couple of online questions that we should probably get to. The first was from Dr. Eastwood, asking about the process to apply to use the database. Would you like us to promote its use at the Center for Health Informatics? And I could probably address this, and Codie, you can correct any errors. So yeah, we do have this formal process. So for people who want to do a research project similar to what we do in Approach, is you need to have a protocol. Ideally, it's been looked at by ethics, but doesn't have to be completely approved before we have a look at it. We comment on feasibility and any associated costs. Usually there aren't many, and then get back to you. And we're happy to collaborate. And if you want to promote it within CHI, Kathy, I think that would be great. We don't tend to necessarily send the data away, but more like to partner with people.
That sounds good.
But to contact us, my email address is
That's right. So if you didn't hear that, contact Dr. Rouleau, Codie, about that. Tim Priers asked about the ability of the rural patient to access this care, and I think we'll leave that one to you.
Yeah, so that's a good question. There's a lot of programs now around the province that do have cardiac rehabilitation. So at the beginning, when there wasn't as clean a process with Connect Care, we were forwarding all referrals that belonged to a different program to that program. So we're helping them out by using our program to help get those referrals to those other little programs around the province. There are some people who decide that they want to do their rehab with us. We're okay with doing that as exceptions. They would mostly be doing that as sort of remote rehab, right? So we would have some way to give them exercise prescriptions remotely, advice. We have the education that can be done. So it can be done. It's not impossible, but I think a lot of the times patients decide they want to stick with their local rehab program, and we're quite happy to help support and help those programs get those patients if needed. But now with Connect Care, obviously the direct referral is a lot easier for them, for their programs. And then, yeah, go ahead, Russell.
So I guess you got into it a little bit there, but do you have any data on what the main barriers are to patients either enrolling or completing the program? You know, is it social, cultural, financial, is it parking, is it distance? What are the factors that make people fail to complete? What are the easy, are there easy wins to change that?
Yes, in the literature, the most consistent predictor of attending cardiac rehab is a strong recommendation from their cardiologist. So make note. In Calgary, however, like there's a ceiling effect. Like generally people are coming and you ask them like, why are you coming to cardiac rehab? And they're almost confused by the question because they're like, my cardiologist told me to. This is obvious. But beyond that, some established barriers include like transportation and instrumental issues. So I can't get there. I don't have a car. I live out of town. And because of that, that's why we offer like a home-based program for patients unable to join. There is also like the theme of like comorbidity, functional status barriers. So I'm too sick, exercise is tiring and painful. So there's like the catch-22, as you just saw in our data, that if you can get them through the door, there's a good likelihood that comorbidities and functional status will improve. So sometimes that's where that like motivational communication is really important, like educating patients about the benefits of exercise, even if you are sick, even if you do have comorbid health issues. The other big theme is like healthcare system barriers. And this in the literature, less applicable to Calgary because we have automated referral for most of our patients and we get them in the door really fast. And then the other barriers, like the miscellaneous barriers would be like, I have to go back to work. I already exercise at home. Like I'm already fit. I already know how to do this. Those would be the main themes that emerge from our data and in the literature. But by far the most robust predictor is my doctor told me to, so I did it.
To take that a little bit further, you've already identified women don't get referred as much and don't continue on that for a while. Have you taken any steps to address that?
Yeah, so it's a good question. So one of the things about our automatic referral is that we actually get everybody. So we actually do a data extract where we actually get those patients' names sent to us. Anybody who's not been actually referred, so please still refer because they come quickly. But we will then look at that list and we'll be calling everybody. So what we did look, and I don't have this data with us, we did look again at our data for women, and the number of women coming to rehab improved substantially because of this process, because we're not letting the physician think, oh, well, I'm not going to refer. Not that that's happening in Calgary for sure, but you know, there isn't a reason not to refer. We're going to see them regardless of whether you send them or not. It's just going to take longer. And what we know is the longer it takes to actually call them, the less likely people are going to come. So we want to see them quickly. We want their names quickly. That's why the actual referral helps us a lot. And I will say that the cardiologists, nurse practitioners, everybody in Calgary, like when we tell other groups outside of Calgary that, you know, our percentage and the support that we get, they're like totally shocked. It's like, no way. There's no way that you see that many patients. We get 25% of our patients. That's pretty typical of a rehab program is 25%. And we're like 70, 75%. So we're like 3 times their numbers, which is why they don't believe us. And, you know, one of the things we say is, part of that is like an automatic referral. Part of that is seeing them within 2 weeks. But really important is that every single person believes in rehab in Calgary and they tell their patients to come. And I would say that we actually had really low surgical referral rates until we put this process in place that Codie talked about, and I think what Steve talked about, and it's like really improved the number of surgical patients coming to cardiac rehab because they take a little longer to come to us because they have to heal a little bit, but that's improved that as well. And then the early surgical access stuff, that's been very important because we've caught all kinds of things, infections, sternal wound dehiscence, you know, all kinds of things. And the number of patients that we've caught who have post-STEMI, stop the ticagrelor, like, and you're like, oh my God, you stopped, when did you stop, get started on that right away, is I've like lots of patients who have stopped meds thinking that, hey, that was okay to stop this medication on their own. So it's really important to get these patients early and help them kind of go through their journey. And when they come out, they often say, that was the best thing I've ever done. I'm in better shape than I was before I had my heart attack. So it's really important to get these patients through the program. And we see the benefits, which is why we just keep wanting to do it. Like, that's why it's a fun place to work, because you see the benefits of these patients going from being, unable to do things to really, doing quite a bit. And the fact that we have the cardiology fellows in there, seeing that, and then coming back to, to the acute care unit, and they can actually say, what is it that happens to you? That's been really important to have the trainees there to see what we do, so that they can bring that back and understand why they want to promote cardiac rehab. So that's been really important as well. So there was another here, sleep hygiene initiatives. You want to just chat about that? So.
Okay, so the question is, can you elaborate on your sleep hygiene initiative? So I might clarify that. So the process that we've recently implemented is simply measuring people's self-reported sleep duration. So when people come in for their initial stress test and their cardiovascular risk factor review, we've simply added a question that asks, on a typical night, how much do you sleep? And this might be different than the time you spend in bed. And we're measuring this at pre-rehab and post-rehab. So the reasoning behind that is some major organizations, including the AHA, and I mean, CACPR has said this for a while, that like certain types of sleep disturbance are probably linked with cardiovascular risk factor. I mean, sleep apnea is the one we all know about, but there is, compelling epidemiological data linking short sleep duration, long sleep duration, insomnia disorder, shift work, all sorts of sleep disturbances and adverse cardiovascular health outcomes. So at this moment, all we're doing is measuring people's sleep duration, at least what they say they're getting, to start collecting data on this to see, does it strongly correlate with people's outcomes, whereas we don't have a standardized intervention to address sleep disturbance at this moment. It's really like clinician discretion. If they come in for an appointment with Sandeep and show signs of sleep apnea, then the individual physician would initiate those referrals. The difficulty with short sleep duration as a risk factor is there's about 1 million reasons why somebody might not be sleeping enough. So it's really hard to develop a standardized intervention. Like if somebody's not sleeping much because they have insomnia, telling them to sleep more is going to do more harm than good. Whereas if somebody is not getting enough sleep because of pain, that's going to initiate a different pathway. So at this moment, we're measuring it, and it's going to lead to some nice research down the road.
And we sort of alluded to this from the standpoint of our database, just to keep in mind, like every clinical point that we do, including like med data, et cetera, all of that is just part of our clinical care, but all of it is also tracked in our database. So that's why, Steve, when people look at our database, when they finally actually look at our database, they actually learn a lot. So this sleep data is going to be, it's just part of our clinical care, gets added to our data, but it goes into our database. So more and more data is being accumulated over time. And I don't know if you saw there, there were 30,000 patients matched with the Approach database, I think it was. So it's a very big database, and it's very healthy kind of for us to look at this and critically analyze it to figure out what are the components. And the one thing about Codie's study about what are the key elements to improve outcome, we didn't look at SGLT2 inhibitors, right? So there's an opportunity. We can look at that in our patients who have diabetes. How did that actually improve an outcome in cardiac rehab? And was that also, what percentage of that benefit in outcome was related to, starting patients on an SGLT2? And then we're doing initiatives on trying to get patients, more percentage of patients LDL in target, right? So we know that on average, about 36% of people are not in target after a cardiac event in 1 year's time. That's typical. That's Alberta data. We know that. Todd sort of led that research, Todd Anderson. And we looked at our rehab program, we're less than 20% that are out of target. So really, really, we're doing much better. And our goal will probably be more like 10%. or less that are out of target from an LDL perspective because we know it improves outcomes. So again, using the data to help us make changes to again improve patients even further, and that's been our goal. And I think we're
Yeah.
pretty much out of time, so we'll stop there. Thank you, everybody.
Thank you very much. Wonderful. We'll close the program. Thanks.